Somebody going, and gone. 1 through 45 over here, 46 through 81 over there. So everybody give Kristi your undivided attention. I have my hearing aid in today, so I will be able to hear whispering. There yours, Kristi. 806.
Okay, are you guys ready? Yeah. Okay, you're gonna have to let me know if you have an issue hearing me. Since I work in the NICU, I'm always whispering, so if you can't hear me, just let me know. My name's Kristi Devine. I've been following Cherie for the past 2 months for my master's in science and nursing education, so this is my final practicum. I have to teach a class. I'm a registered nurse at Memorial Health University Medical Center. I work in the neonatal ICU, and I'm certified for neonatal intensive care nursing. Today we're going to be talking about a child with alterations in gastrointestinal function. So we can move on to the learning objectives. I want you guys to be able to describe common gastrointestinal disorders seen in the pediatric population, as well as assess them. Explain how to incorporate family-centered care. That's a huge thing right now. Determine expected outcomes for their diagnosis, and identify any psychosocial factors that affect them in their life. A HESI hint here would be that nutritional needs and fluid and electrolyte balance are key problems for these kids, especially in the pediatric population. They do lose water easier than adults. So moving on to dehydration, children are at greater risk than adults for fluid and electrolyte imbalance. They have a higher percentage of total body water, a higher metabolic rate, and immature kidneys, so they have issues excreting toxins. I've highlighted infants under 6 weeks old do not produce tears, so you need to keep in mind when you're taking the NCLEX or HESI exam, you're not going to consider their tear production as part of your assessment for their dehydration status. When you're assessing them, you're going to check their heart rate. It'll typically be tachycardic, but since they're having hypovolemia, they're not doing a good job pumping their heart. So their pulses peripherally will be weak and thready. Their skin, eyes, oral mucosa will be dry, and then fontanelles can become sunken with severe dehydration, sometimes moderate. And remember too, when those soft spots close, because that will not be part of your assessment on, say, a 2-year-old. Their mental status, you're gonna talk to mom and dad. Is the baby acting how they normally act? Don't try to figure that on your own. You need to ask the parents. Capillary refill might be delayed, and urine output for an infant is 1 to 3 milliliter per kilogram per hour. So anything less than 1 is a little concerning. And then obviously you're going to restore fluid volume and prevent hypovolemic shock. Sorry, it's not moving. These are, again, the clinical indicators just for you to look at. They will have tachycardia, which is an initial sign, and later signs are hypotension and hypovolemic shock. I wanted to talk to you guys about different types of dehydration. Embarrassingly enough, I did not know about this prior to this lecture, and I was at a conference with some of my MSN students, and we were talking about dehydration in our patients, and I talked about how our patients usually have hypernatremia, and she told me that's impossible. You have to have low sodium to be dehydrated. So she really looked down at me and she said, "You're just a NICU nurse, it's a lot different." So now that I know this, I wish I knew it back then. It explains why we both had differing types of dehydration. So the first type is isotonic, and water and sodium are lost in equal amounts. This is the most common type of dehydration, and you might not see any difference in your sodium level. It might just be normal, and your patient will have a low urine output. In hypotonic dehydration, the electrolyte deficit is greater than the water deficit, and we're talking extracellularly. So the patient will have a low sodium. Does anyone know what a normal sodium is? Yeah, like 130 to 150 is what your textbook says. 135 to 145 is more specific. So these patients will have a sodium less than 130, and their cells will start to swell because there's more sodium outside the cell. There's more sodium inside the cell, and the water will follow into the cell. So you can see the picture, water is always following sodium. You need to remember that for your NCLEX. And then hypertonic dehydration is when the water loss is greater than the electrolyte loss. So you're gonna have a really high sodium, greater than 150, and the water will move outside the cell, and the cells will shrivel up. So this is the most serious type of dehydration and can cause seizures. I wanted to also remind you guys, when you're doing sodium supplements to a patient, you never rapidly restore their sodium levels. So if you have a patient with a sodium of 120, they will survive a week of you trying to get their sodium back into the normal range. But if you went from a sodium of 120 to 145 overnight, you could kill that patient because they would get cerebral edema. So sodium is always affecting your brain. So we restore their sodium levels very slowly and carefully. As far as replacing fluids, for mild to moderate dehydration, you're going to do oral replacement solutions like Pedialyte. Gatorade is not preferred since it has such a high sugar content, but you can cut it down with water. Severe dehydration will need IV therapy. And then you can see in those pictures the different type of dehydration and how the cells get affected by it, and how the isotonic solution, keeps the cell normalized. And that would just be normal saline. All right, and then moving on to diarrhea, which usually causes dehydration. You want to obtain a really thorough health history. So sometimes parents don't know that when they change formulas, they need to wean them off of it, just like you do with your dog and dog food, which is a terrible way to relate it, but it's true. So you need to ask what the baby has been eating, because they might have just changed the formula overnight, and that could cause diarrhea. You also want to talk to them about if they go to daycare, if they've been exposed to anyone who's sick. And then sometimes little kids have pica. Does anyone know what that is? Yeah, so it's when you eat inanimate objects that are inedible. So kids will do that all the time, and it's not a psychological disorder. So you need to ask the parents, have they been eating weird things? You can do a stool culture and sensitivity to see if there's any type of bacteria growing in their stool. You could also do an occult blood to see if there's any blood in their stool. Serum electrolytes would be obtained on a basic metabolic panel or a complete metabolic panel, either one. And then most doctors are just going to order a CBC without the differential, but they might order the differential, which is just breaking down all the white blood cells to see if they have any indicators of being septic. I don't know where to point this. Sorry. Okay, so as far as nursing management, you're going to restore fluid and electrolyte balance like we talked about in the dehydration slide. You're not going to do the brat diet. It's not recommended, probably because kids are really picky eaters, and if you restrict what they can eat, they're not going to eat anything. So the doctor might order this diet, and you can advocate for your patient and see if they could eat something else. You're going to provide education to the parents, so they always need to be washing their hands. Sometimes you need to reteach personal hygiene. For example, in the NICU, parents are always taking really nasty, dirty diapers and then throwing them by a bulb syringe or the baby's face while they swaddle them up before they throw it out. So remind them that you shouldn't put dirty diapers near their mouth or anything that goes in their mouth. Clean water supply is a huge one. A lot of people have a misconception that if they take hot water out of the tap, it's a lot cleaner than cold water, which is not true. If you take hot water out of the tap and feed it to your baby, all of the grime from the pipe is getting in the water, and now your baby's eating that. So some people can't afford nursery water, so you need to teach them that they can take cold water from the tap, boil it, and let it cool down and use that for their formula, or they could just take cold water and microwave it, which is not preferred, but sometimes you have to teach them this. And then obviously careful food preparation. Can you guys hear me? Okay. And then for diarrhea prevention, it's always about washing hands. And then remember, we're gonna avoid excessive juice intake. It doesn't really help because it's so high in sugar. Another thing I was thinking about when I was writing this is you can remind parents they can cut juice down with a lot of water so that they're not taking in all this sugar. And then this is just a review of the brat diet. It is just really binding foods like rice, applesauce, bananas, and toast. Again, it's not recommended, but sometimes the doctor's still gonna order it. And then gastroenteritis, it's an infection of your intestines that usually causes watery diarrhea. This can be viral, parasitic, or bacterial, usually caused by viral infections, and the most notorious one is norovirus. You're going to obviously maintain hydration and nutrition, and stool culture, and wash hands. I put the metabolic alkalosis and acidosis slides after these because a huge thing is when a patient is excessively throwing up, they will develop metabolic alkalosis because they're throwing up all the acid in their stomach. And then when a patient has a lot of diarrhea, they can develop metabolic acidosis because they're pooping out all the bicarb in their body. So to determine if your patient has this, you're gonna do a blood gas, either venously or arterially, and you'll get a pH, a bicarbonate level, and why can't I think? And CO2. So this is just another picture to help explain that relationship. And then this diagram will just explain to you that in metabolic alkalosis, the bicarbonate is increased, and that's why it's metabolic, because your kidneys are pushing out bicarbonate to help restore your carbon dioxide levels. And then in metabolic acidosis, your kidneys are not pushing out bicarbonate to help restore your carbon dioxide levels. And then you can see in respiratory acidosis and alkalosis, the carbon dioxide levels are shifting, but there's nothing wrong with the bicarb. So that's why that's respiratory and that's metabolic. Okay. So Hirschsprung's disease, I decided to put the medical terminology for this. It's also called congenital aganglionic megacolon. So if for some reason they put that on your NCLEX or HESI, it tells you exactly what is going on with this diagnosis. It's congenital, it was genetic, it was in utero. They are missing nerve cells because that's what ganglions are, and they have a large colon. So in this disorder, they have nerve damage in their colon, and it's causing the stool to get backed up and the rectum to shrivel up. So all the stool gets constipated and stays in the colon, and when the patient does stool, if they do, the loose stool will come around the hard stool, and it will come out looking ribbon-like and be really foul smelling. So a lot of times you'll see that on questions. Sometimes it'll say pellets too, because if they do poop out any of the constipation, and that's what that is. And a HESI hint would be to always take an axillary temperature, and that's kind of a good thing to remember. With any patient that has a GI problem, you need an order to take a rectal temperature. You don't just go ahead and do that. Over there, there's a picture of an x-ray under barium, and you can see that the patient has a large colon where the red arrow is. So in these patients, you might not see any meconium, which is the first stool, for 48 hours of life. They might have failure to thrive, poor feeding, chronic constipation, and then it's typically seen in male patients that have Down syndrome. And then in older kids who are stooling, you're going to see in the question ribbon-like or foul-smelling and pellet-shaped. So as far as diagnostic evaluation, you're always getting an x-ray if your patient has something wrong with them GI-wise and you don't know what it is. And then as you can see in the slide, 2 ago, when they got the x-ray under barium, it's quite obvious the patient has Hirschsprung's disease. And then that would lead them to doing the more specific diagnostic evaluations. So a rectal biopsy is going to show you that the cells in the colon are aganglionic or do not have ganglion cells. Rectal manometry is when they put some pressure up into the rectum, and the patient with Hirschsprung's disease, the pressure is either going to increase or stay the same. In a patient who's healthy, it will decrease. So those two things are gold standards for diagnosing Hirschsprung's disease. As far as fixing the problem, it all depends on the severity of the nerve damage. So if the patient's entire descending colon is aganglionic, they're not going to be able to fix it overnight. It might take a very long time. But if it's only, half a centimeter of the colon is aganglionic, they can resect it, which means to take it out, and then they can put it back together, which is called reanastomosis. So if they do have really bad nerve damage, they might need a temporary ostomy. So that's going to help the patient be able to stool while their intestine is growing, and then the surgeon can put everything back together once they've grown more tissue. But sometimes if the nerve damage is so bad, they would need a permanent ostomy. Oh, I'm sorry, I forgot to. And then the pull-through procedure is when they get the permanent ostomy, and then later on, they put everything back together, okay? Cleft lip and cleft palate. You can see the baby at the top left hand for you guys has a cleft palate on the left side, and the one on the right has a cleft lip and cleft palate. So you can have one or the other. You can even have bilateral cleft lips. I don't know if anyone's seen it. And this can be really alarming for parents to see if they didn't know that they were having a baby with this problem. So you need to be really sensitive to them and help them bond with their baby. So they're always going to usually go to the NICU. So instead of sitting at your computer and let the mom just go into the room and not say anything to her, you need to go up to her and ask her, do you want to hold the baby? Do you want to do the feeding? That type of thing. You want to encourage her to do things. And sometimes she'll need a nudge because they might be feeling depressed, wondering, why am I, feeling this way and not able to express it. So you need to help them get through that. And then if you see at the bottom left side, there's a baby eating out of a specialized bottle. You need to remember these kids do not get surgery right when they're born. I'm not sure the reasoning. I think it's because people don't want to do surgery on a newborn baby right away. So they do have specialized bottles they can eat out of, so they don't have to, just be on IV fluids. So they have a really big issue getting a seal on the nipple. So these special nipples were made by a lady in England whose child had cleft lip. And I believe it was because he was a lot better at breastfeeding than he was at bottle feeding. And she wanted to develop a bottle that helped mimic that. Breastfeeding is a lot slower than bottle feeding. So this bottle is called a Haberman feeder. And the baby is able to get milk out slower. And the caregiver, if you look where this person's hand is able to squeeze the nipple every time the baby sucks, and that helps get the milk out. So you want to teach the parents how to use this. You might need to contact OT and get taught how to do this. I'm not going to lie to you, this took me years to get good at. This bottle is not easy to use. It's not easy to put together. So you need to really support the parents in learning how to use it. It's called a Haberman feeder. When the babies do get surgery, if you look at the top right-hand corner of picture, they have to wear elbow restraints so they do not pull out their sutures. You can take these off every 2 hours, one at a time, and do range of motion on each arm. You don't take them off all at once because the baby, might lose control and get at its sutures. Your book said that they only need them on when they're supervised, but I think that's a pretty bad idea. You should just leave them on. And then if you look, you need to teach the parents too that when they're feeding the baby, they need to check temperatures of food. The baby's not gonna be able to feel hot food on its palate for a while. They have nerve desensitivity after surgery. You need to teach the parents how to use the feeder, and you need to teach them to give pain medication, to not let the baby excessively cry. They need to be comfortable, but they cannot have a pacifier, and I'm sorry, I forgot. And the parents need to learn how to clean the sutures. That's it. And if you look at the baby at the bottom right-hand corner, I'm sure you guys in the back can barely tell he even had a cleft lip. So a lot of parents are scared that their baby's going to surgery and they're going to have this huge scar on their face for the rest of their life. So that's how it used to be in the past. They weren't so great at fixing cleft lip. But nowadays, the scar is barely visible. So remind parents they will look normal after this, and probably within about a year, all their surgeries will be done. And a HESI hint is that they have alteration in nutrition, less than body requirements, due to decreased ability to suck. The next one is pyloric stenosis. This is when there is stenosis or hardening of the pyloric sphincter, which is the sphincter at the end of the stomach that empties the stomach into the duodenum. So these patients, once they eat, they're going to have projectile vomiting. And they're going to try to trick you on NCLEX and HESI by saying 2 hours after they eat or an hour and a half after they eat. No, it's right when they eat because their stomach cannot empty. They're going to have insatiable appetite, and they're going to be extremely fussy and angry. They can have visible peristaltic waves, which is just, the intestines moving. And then sometimes where the pyloric sphincter should be, they have an olive-shaped mass, which is just the stenosis. And then they obviously have electrolyte imbalance because they're having an issue with their nutrition and electrolytes. This can be surgically repaired. And they, too, like cleft palate babies, have an alteration in nutrition less than body requirements, but that's due to frequent vomiting. So they will have metabolic alkalosis, and they'll have an increased bicarb and an increased pH. As far as intussusception, this is telescoping of one of the parts of the intestine into the other part. You can see the picture at the bottom, what's going on. This happens in children under 1 year of age, but it can also happen in adults. They will have acute pain where they're screaming their heads off, their legs will be drawn to their chest, and then once the intestine moves out a little bit, they'll stop being in pain and act normal. So for these kids, you want to ask the mom, what are they doing when they're in pain? They'll have current jelly stool, and they'll have a sausage-shaped mass in their upper right quadrant. That's where all the backed up intestines is. And then in their right lower quadrant, there'll be a concave cavity of emptiness. In your slides, I had a typo there, so just make sure you fix it. And you're gonna monitor them for perforation and shock. They can lose blood flow to the parts of the intestine that are folded up on themselves, so they can get very sick. Sorry. Okay, so appendicitis is inflammation of the appendix, And you want to remember that these patients are in a lot of pain in their right lower quadrant, and if they suddenly stop having pain, you want to be very scared because that means their appendix probably ruptured. So you need to remember that. And if you're working in the ER, it doesn't mean you're going to send them home because they got better. It means you're going to get them to surgery. And I know we hear of appendicitis all the time, like it's not a big deal because surgery is so successful. But if you miss an appendicitis case, that patient can rupture, get septic, and die. So make sure you're getting them to surgery and getting them with IV antibiotics. Tracheoesophageal fistula. This is when there's an abnormal connection between the trachea and the esophagus. If you look at the middle picture down there of all the different types of TE fistula they can have, the middle one with the green arrow is the most common. This is when there's a blind pouch, the esophagus goes to nothing, and luckily it is the top part where they're ingesting food is not going into their trachea. That's the most dangerous type, when their esophagus goes into their trachea. So this type, they'll eat, it will go into the blind pouch, and they'll vomit. A lot of times they'll try to trick you on questions too. These patients will get suction put into their blind pouch to low intermittent suction. I don't know if you guys can conceptualize this if you haven't seen it. So a lot of times, you know, when they put an NG tube in to decompress the stomach, it's that type of thing, and they'll put it to the suction on a very low level. The suction will turn on and off intermittently so the patient isn't getting ulceration to the side of that part of the esophagus. That's a lot of times you'll be like, why would they put something in the blind pouch? That makes no sense, but they do. And you want to remember these patients are the 3 C's: coughing, choking, cyanosis. And it's very obvious why. If they ate something and it went into their lungs, they're going to choke, cough, and have cyanosis, which is just when you can't breathe and you get blue. Does anyone have questions about that one? Okay. And I wanted to remind you guys about this one. To fix this is not easy. Just like the Hirschsprung's disease, how we were talking about, a lot of times they have to stretch the esophagus. So it can take months for the esophagus to stretch so that they can get it to the other piece and put them back together. These kids get very sick. And we actually had a baby in the NICU for 6 months getting this repaired. And when she went home, there became a hole between the esophagus and the trachea, and she almost died. So they get very sick, and it's not easy to repair. Celiac disease. This is a disorder, if we're going to say it simply, where your intestines have an immunological response to eating gluten. So gluten is any kind of wheat, rye, or barley. And I put this here that they can eat rice and potatoes because sometimes people overthink, is a potato gluten? I don't know, you know what I mean? So I put them both there if you're trying to figure out what kind of starch they can eat. They do have bulky, greasy, foul-smelling stools, the steatorrhea, if they do eat gluten. And then remember, if they do not know they have celiac disease and they keep eating gluten, their body is unable to absorb fat. So they can become very malnourished and anorexic and have a protuberant abdomen. Okay, ostomy care. Remember that you play a huge role in teaching the mom how to take care of the ostomy. We recently had a baby in the NICU where she was a term baby. They had no idea she had imperforate anus, and she got shipped to the NICU within 1 day of life, and the mom came in completely stone-faced, overwhelmed, in shock that her baby was going to have an ostomy for the next year of her life. So you need to help them cope through the loss of having a normal child, and you need to teach the mom that you're going to help her become an expert on her child and get her through this. As far as caring for the ostomy, you want to make sure when you cut the hole for the bag, it's snugly around the stoma so that there's not any skin being revealed. That skin will if stool gets on it, can break down. So if you're unable to do that, you want to consider putting ostomy paste over that skin to protect it. it becomes like a hardened piece of like barrier. You put the paste on and then it hardens. And then for babies, your book says to put them in a onesie outfit to protect their ostomy bag, which is very true. If you put him in a t-shirt, that little guy down there, his t-shirt would ride up and then his bag would rip off. So if you put him in a onesie, they'll be more protected. I think that's it. Oh, yeah. Does anyone have any questions? No? Okay.